morning from Miami Beach. This is Dr. John Bennett, home of Neurosurgical TV. We are graced with the presence of Ibrahim Sabeya, a well-known educator from Jordan. He's been doing this for 28 years. I was wrong. I said 27 last week, but he corrected me. Okay, we'll let Dr. Sabeya run the show. Okay, welcome, Dr. Sabeya.
Thank you. Okay, good morning, good afternoon, good evening, wherever you are. I'm Ibrahim Sabeya, and we are transmitting here from Amman, Jordan, from the Farah Medical Campus. It is a pleasure to be with you, as always. This is the Black Iris Symbol of Jordan. And today, it's a great pleasure and honor also to present my colleague and friend, Professor Kore Özdemen, from Acıbadem University in Istanbul. We will both present to you the topic of pineal location tumors. I'll be talking about the microsurgical part of these lesions, and I will discuss the clinical, radiological, pathological, and operative findings. And the Professor Özdemen will discuss with you the radiosurgery part of these pineal location tumors. I always start by saying, why do we call it pineal tumors? A lot of people would mistakenly name them differently. The correct terminology, the correct way of spelling them is pineal, and it's coming from the pine tree. It's because it has the same picture, the same appearance like a pine tree. Here it is. That's the pineal, deep-seated gland. Superior colliculus, inferior colliculus, back of the midbrain. On both sides, you have the temporal and then the thalamus posteriorly. So this is the superior colliculus, inferior colliculus, the pineal gland, and this is the posterior part of the thalamus, pulvinar. Again, it's tucked like this, deep, superior colliculus, and lots of vessels around it. That's the secret of difficulty of these tumors, the way we treat them. So I'm just showing different angles of this pineal locus, superior colliculus, inferior colliculus, and here we have the fourth nerve, the trochlear nerve. Also here is the pineal gland, superior colliculi, inferior colliculi. So, different angles so that we can imagine where it is. And here it is, pineal gland, pulvinar, third ventricle. We are at the posterior end of the third ventricle, superior colliculi, both sides, inferior colliculi. You go downwards, you will reach to the cavity of the fourth ventricle. Of course, you have the superior medullary velum, and you have the superior cerebellar peduncle. Here it's closed view, the pineal gland, tucked at the back of the third ventricle, the superior colliculi, inferior colliculi, superior medullary velum here has been removed to show you the cavity of the fourth ventricle and the superior cerebellar peduncle. Again, if you look at the pineal being here, it is surrounded by so much veins, and we have to understand the anatomy of those veins if we want to operate in that area. It is not that difficult, but it needs to be really taught well and seen well so that it will just stuck in the mind of the operator, and then we can proceed with surgery. Here we have the two internal cerebral veins to form vein of Galen. They'll be joined by the basal vein of Rosenthal. This is also will be joined by the lateral mesencephalic veins, etc., etc. We will be alluding to this many times later on. So here we are infratentorial. Cerebellum has been tucked in here this way. And this is the vein of Galen. And as I said, we have the internal cerebral veins here, joined by the vein of Rosenthal laterally. Above the vein of Rosenthal is the internal occipital vein coming from the occipital lobe, which is above the tent here. Here you will be seeing some branches of the posterior cerebral artery, but as you know, once it is here, it will jump above the tentorium. So just seeing some branches of it. But the main vessel that you will see here would be the superior cerebellar artery. And in here, we'll find a major branch from the P3, P2, from the posterior cerebral artery, which is the medial posterior choroidal artery. So these are the difficulties. The splenium, underneath it you have the pineal, underneath it you have the colliculi, and it is surrounded by these tuft of veins that you should know exactly where they are, because any damage to these major vessels, especially basal vein of Rosenthal or internal cerebral veins or vein of Galen, can lead to very bad results. So different pictures just to show you the area. If we go laterally from the area of the pineal gland, then you will see the trochlear nerve going to the free edge of the tent, and you will find the superior cerebellar artery. As I said, you will not see the posterior cerebral artery because it's jumped over the tentorium here. If you remove the tent, to complete the picture, remove the tent, then you can see all the branches of these vessels, basal vein of Rosenthal, and the branches that's coming from the internal occipital and cervical vein, etc., etc. A lateral view of the splenium, the corpus callosum. Here is the tectal plate, the inferior colliculus, the superior colliculus. Here is the posterior commissure, and then we have a recess that takes us to the pineal gland, and there is suprapineal recess, and then we have the habenular commissure. So habenular commissure above and posterior commissure below. Of course, anterior commissure is this way at the upper level of the lamina terminalis. Again, the general view of the third ventricle, the tectal plate, quadrigeminal plate, and the inferior colliculus, the superior colliculus, posterior commissure, the gland with its recess, and here is the habenular commissure. Corpus callosum, the splenium, the internal cerebral veins, vein of Galen, and then you have, see this vein is covering the pineal. It's called pineal vein, superior pineal vein, comes from either the pre-cerebellar central vein or directly from vein of Galen. So if you want to operate on this area, you have to be familiar with this anatomy, otherwise you cause damage to your patient. In close look at the pineal gland, how it is tucked, splenium, internal cerebral vein, vein of Galen, and then the important structures of the midbrain. This is how it looks radiologically: inferior colliculus, superior colliculus, posterior commissure, and the pineal gland. Here is this shows that we have two sort of legs or pair of legs for the pineal gland, upper and lower. The upper coming from the posterior, from the habenular commissure, and the lower coming from the posterior commissure. So two legs to join this body of the pineal gland. Internal cerebral veins joining to form vein of Galen that will come to be straight sinus, and here we have very thick arachnoid. This is the thickest arachnoid in our brains, and I will allude to this later on. And this is, of course, the quadrigeminal system. On the sides of the brain stem, other systems that we don't need to discuss now. But again, you have to appreciate that we have inferior colliculus, superior colliculus, the posterior commissure, the gland, and the habenular commissure. Again, here the two legs of the gland, the upper coming from the appendular, the lower coming from the posterior commissure into the gland, sitting underneath this. Beautiful paper published recently, I think 2018, showing the very thick arachnoid surrounding these structures. As you go to the midline, it is very thick. As you go laterally, where the quadrigeminal cistern joins the cistern ambiens, it gets less. So if you want to dissect this arachnoid, you may need to actually use sharp dissection with the knife. And using the knife in this area is very important that you know what to do. So always start laterally and then go medially. Laterally, the arachnoid is less thick. Again, showing the thickness of these arachnoids. The anatomy here is very important. You'll be operating in this area, and you need to know exactly what you are doing in 3D. Same thing here, the gland, the internal cerebral vein going to vein of Galen and the other veins in this area. I always refer to this beautiful 3D picture that you will find it in the books of Yesergir, I think volume 2. It's beautiful, it's very illustrative, showing the internal cerebral veins coming from the anterior septal thalamus striate, joining together to form vein of Galen, becomes the straight sinus. And then this is the inferior sagittal sinus joining two, and joining them laterally is the basal vein of Rosenthal that drains the frontal, the temporal, anterior, middle, and posterior temporal veins. And here you can see the tent, and you can see how many sinuses in the tent. So if you want to open the tent in this area, and you may need in certain approaches to the pineal gland, you have to be aware that these venous sinuses, these tentorial venous sinuses are of great importance. Of course, here is the vein of Labé. So here is we are looking from above, from posterior, you can see internal cerebral veins joining to form the vein of Galen and the straight sinus. Now, is this sort of routine? Is it the same pattern? The answer is no. Again, this is from books of Yesergir, showing you the many, many variations of how the basal vein of Rosenthal and the internal cerebral veins join to form the straight sinus. So look at these angles here. This is sagging angle, this is right angle, this is really like a loop here before joining. So many, many variations that one has to read carefully and study carefully the venous anatomy before embarking on any surgical procedure. Why do I put this? This is a handbook of neurosurgery by Mark Greenberg. Mark Greenberg is a very elegant neurosurgeon. He wrote this book as he was a resident and student to summarize his findings, and he put it in a book, and he called it handbook or bucket book or whatever, notebook, but it is not a textbook. Why people in the Middle East and the underdeveloped countries read this as the final ultimate standard textbook defeats my intelligence. So any neurosurgical resident, any young neurosurgeon should be reading from textbooks. You choose what kind of books you want. You choose what is the textbook that you want to keep with you or your life. I have chosen that a long time ago. I was guided by my bosses. God bless their souls, in Atkinson Morley Hospital in London, St. George's University. I've read the Yesergir, I've read the Russell Rubinstein pathology, Anne Osborne books of imaging, Rotman books of anatomy, a neurological book of John Batten, and I read from the many neurosurgical journals. And that's what a neurosurgical resident and young neurosurgeon should do. You will not finish this book even if you become 70 or 80 years of age, but keep them as your companion. And these are the journals, and it happens that these journals, which I read every month, I am on the editorial board or in the advisory board of these 7 journals, locally, internationally, Asian and international. Pineal gland is an endocrine gland. It secretes melatonin, and it has the function of regulating sleep, not alone, but in conjunction with the supraoptic nuclei of the hypothalamus in conjunction with your eyes and what light comes in. So melatonin secretion, it increases in the evening, and when it is there, you feel like you want to sleep. In the morning, the secretion decreases and you wake up. So this cycle of melatonin and the cortisone and the supraoptic nuclei will make our life the cycle of waking and sleeping. If you are traveling in the airplane, they keep the lights on most of the time. You don't know whether it is night or daytime. And because of the lights, the secretion of melatonin decreases. That will keep you awake. So when you land in wherever you are traveling, east or west, I found that the worst jet lag ever is when I travel to Japan, when I travel east, less if I travel to the States, for example, to the west. So that is the function of melatonin. So this is the hormone that causes us to sleep. The lights coming from your eyes during the night or day goes to the retina to the supraoptic nuclei, and it will go to the pineal gland through many pathways. So melatonin secretion increases at night, so this is midnight, and decreases in the morning. So cortisol, the melatonin will make our cycle. And that's the relation with the suprachiasmatic and supraoptic nuclei of the hypothalamus. And sometimes people with pineal gland lesions, it can affect these pathways between the supraoptic and suprachiasmatic nuclei and the pineal, and that can affect the sleep of the patients. So what about these pineal locus tumors, pineal location tumor it's called? I think locus is a good name for it. Let's see that it is less in adult, more in children. So if you compare the frequency between adults and children, it's almost 10 times more in children. So, oh yes, 10 times more in children. But the difficult thing about it is that 3/4 of them are malignant and 1/4 is benign. Pineal gland is made of pineal cells, of glial cells, and of the residual germ primordial cells. So when there is a tumor coming from the pineal gland, will be expressed in terms of the cells that are there. So you will get pinocytoma, you may get astrocytoma, and from here you will get germinomas. So pineal locus tumor from the gland itself or from the structures around it, or it could be metastasis. 4 main groups: the germ cell tumors, 50 to 70, the pineal parenchymal tumors, the glial tumors, and the miscellaneous, which we will allude to. So the commonest are the germ cell tumors. And these, in turn, are subdivided into 2 types, the germinoma or true germinoma and the non-germinoma or false germinoma. Germinoma respond well to chemoradiotherapy. That's why it has this importance. If we can diagnose it beforehand, we may not need for any surgical procedures, not even a biopsy. And germinomas, as you know, because the journey of the primordial cells is this way, between the pineal and the supracellular region. So when you never have germinoma, most of the time you find it located supracellular and in the pineal locus tumors. Some examples of these germinomas. The other type, as we said, we have germinoma, true germinoma, and the non-germinoma. The non-germinoma are the teratomas, the yolk sac tumor or endodermal sinus tumor, that's the old name, embryonal carcinoma, and choriocarcinoma. So this is true germinoma. These are non-germinoma. Examples are teratoma, and they're characterized by this appearance, very much so. Mature cystic teratoma, immature teratoma, again, have same appearance. endodermal sinus tumor, and in this case they have put a shunt, and I will allude to this in a big way later on. Embryonal carcinoma, choriocarcinoma. The second group, so this is the first group, the germ cell tumors, whether it is true germinoma or non-germinoma. The other types are the pineal glandular tissue, so-called pineal parenchymal tumors, and they constitute about 30%. These are either coming from the pineal epithelium called pineocytoma, or they are arising from a primitive neuroectodermal called pineoblastoma, and you have the intermediate type. So pineocytoma, intermediate, and pineoblastoma. Pineocytoma grade 1 is benign, pineoblastoma is malignant. So this is the pineocytoma, less aggressive, usually young adults. Intermediate is aggressive, but less aggressive than pineoblastoma. Example of this intermediate parenchyma, and the malignant, which is the pineoblastoma, very malignant, and unfortunately comes more in children. Examples of these pineoblastomas. A new type has been added recently in the pathology books, the analgae primary parenchymal tumors that has been mentioned recently. It's either neuroepithelial or ectomesenchymal, and it has no endodermal differentiation. A type that has been described recently is the papillary type. This is a recent classification. And my colleague from Jordan, very prominent neuropathologist at King Hussein Cancer Center, Dr. Maisa Al-Husseini, as she trained in the States, she published this paper. She looked at 17 registers in the SEER data in the period between 73 and 2005. That's 32 years. Published this finding in Journal of Neuro-Oncology 2009. She found 633 patients, and she found that pineocytoma is the commonest, followed by pineoblastoma, followed by the mixed or the intermediate. I hope Dr. Maisa will be with us today so that she can comment on that later on. This is also the pineal analgae tumor in a 5-month-old patient in Journal of Neurosurgery Pediatrics. These are the papillary tumors that I've just described. What about tumor markers? What do we mean by tumor? Well, these are markers that we'll find in the CSF or in the serum, and they would help you in making a diagnosis. And more importantly, and also important, is to follow the effectiveness of your treatment. So I've looked it up and I found this recent paper, 2019, about the biomarkers and what is the update on these biomarkers. So they looked at the subtypes, germinoma, teratoma, carcinoma, etc., and looked at these markers like alpha-fetoprotein, fetal-human chorionic gonadotrophin, placental alkaline phosphatase, and looked where they are. There is some change of the pattern of these biomarkers than, say, 10 years ago. I will discuss that. So if you look at germinomas, teratomas, yolk-sac tumor, embryonal carcinoma, choriocarcinoma, parenchyma, and look at alpha-fetoprotein, human chorionic gonadotrophin, placental alkaline phosphatase, and melatonin, you'll find different examples. So the value of alpha-fetoprotein and human chorionic gonadotrophin is less than what it was before. Germ cells, for example, the alpha-fetoprotein is positive, the beta human chorionic gonadotrophin is positive. If that is the case, and it looks radiologically the same as you would expect it, then you would diagnose it as germ cell. There's no need for surgery, there's no need for biopsy unless you are uncertain. You go immediately for radio or chemotherapy without surgery. So these are the, this is the importance of these biomarkers. What about melatonin levels? Little clinically applicable, It may be good in monitoring treatment. Some people say that if you remove the gland completely, then melatonin will drop and then patients will have sleep problems. Other people would say nothing happened in the clinical practice. So as I said, things are getting more difficult. Germinoma and choriocarcinoma, they have increased beta chorionic gonadotrophies. Germinomas, they have increased lactate dehydrogenase and placental alkaline phosphatase. Other tumors, they have alpha fetoprotein. So things are mixed. So you cannot really count completely on the biomarkers. But if the biomarkers and the radiological appearance and the clinical appearance would help you diagnose a germinoma, then there's no need for surgery, just go for radiation or chemistry or chemotherapy. So we finished the two main groups, which is the germinomas and the parenchymal tumors. What about the tumors of the supportive and adjacent structures? They are only constituting 10%. These are tumors like pineal astrocytoma, one patient of mine, oligodendroglioma, and again, look at this, shunt has been put. I will come back to that later on. The glioblastoma multiforme in that area, ependymoma of the third ventricle presenting backwards like this, looking like a true pineal tumor, meningioma, the facultative junction, dermoids, epidermoids, lymphoma, and this is also a recent paper from New York showing this pineal gland lymphoma. This is one of my cases, an Iraqi girl coming with these tumors, and this is a lymphoma, the pineal locus. Fourth type of tumors is the non-neoplastic, degenerative types, etc. Arachnoid cyst, pineal cyst, septosarcosis, cavernomas, aneurysm of vein of Galen, etc. This is an example of the arachnoid cyst, pineal cavernoma, vein of Galen malformation, pineal cyst. And I will just allude to this in a little bit of details because this is important. The number of cases that have been diagnosed because of the intervention or invention of the MRI, but doing more MRIs and we are discovering these pineal cysts. Over the last 20 years, I had about 25 cases of pineal cysts. And so this is for me is much more than one used to see. And you will find that they have proteinaceous material and they are surrounded by gliotic layer. But look at this. If you see this, and people are referred to me with these cases for surgery, you have to think really deep and careful whether this is a pineal cyst or a pineal tumor with some changes in it. Examples of the cases that I have seen recently, all pineal cysts. And here you would see this. Is this blood vessels or this contrast enhancement? So different types of pineal cysts. So as I said, that this is increasing frequency. They are either ISO or hyper in T1 and T2. They have a very smooth rim. There's no nodularity in it. It enhances smoothly, and usually there is some septation in it. So all these would tell you whether this is a pineal cyst, leave me alone kind of lesion, or is it a tumor. Look at this recent paper, not recent paper, a very good paper, 2009. It's entitled Prevalence of Pineal Cyst in Children and Adults. They looked at more than about 15,000 patients who had MRI for various reasons, incidental finding in 280 pineal cysts. So 2% of these patients had this. This is high frequency of these cysts, but they are more in females, and that's why people are thinking of female hormones being responsible for these cysts. Here is another paper, 2016, 230 patients, 32 patients, 56 had cysts in it. This could be single cyst or multicystic and so on. What about these cysts? Do they stay the same? 50% stay the same, increase in 40% of cases. They decrease in 10% of cases. The message to take home here is don't jump on these pineal cysts, just observe them. And when you observe them, you have to notice that they are associated with other intracranial cysts like arachnoids and choroid plexus cysts. So why are they, how they are formed? Either ischemia or degeneration or hemorrhage inside, or as I said, female hormones. Serial imaging shows cysts do not change with time in 50% of cases. You may find pineal apoplexy, like pituitary apoplexy, and this may cause sudden death. It has been reported in literature. Sudden apoplexy in the pineal tumor, acute hydrocephalus, and death. The last time is the metastasis, and we know that there is absence of blood-brain barrier there, which makes the pineal gland a good site for metastasis. And these are the kind of metastases that you see. This is from bladder metastasis, a paper recently. In addition to all these lesions and their differential diagnosis, there are other lesions that come there in the midbrain, brain infarct, or you have bleed inside.
I'm sorry.
Globus.
I'm sorry. I'll get that. I'll get that.
Sure. Wernicke encephalopathy, osmotic demyelination syndrome, especially in children. All this should be in your differential diagnosis. How do they present these pineal locus tumors? Either by raised intracranial pressure by causing hydrocephalus, and this is the commonest, or they present with eye signs. And that you would see in 80% of cases. You may find cerebellar signs, you may find pyramidal signs, you may find endocrine signs, depending on the size and the direction of growth of these tumors. Okay? So headaches, Perennial syndrome, hydrocephalus manifestations, or as I said, hypothalamic infiltration. So what is Perennial? Henri Perennial is a French physician, and he discovered this syndrome, and it's been called after his name, Perennial syndrome. So basically, it's a midbrain compression level. Let's start. Hello?
Yes.
Yeah, we will just show a little short video about this Perennial syndrome.
Okay.
So a patient is asked to look both sides. There's some nystagmus. Looking up, she cannot look up, so the absence of upward gaze. Of course, there are some pupillary changes with that. And this is the so-called also the sunset appearance that one sees in the hydrocephalic babies. So what's the treatment of these cases? I will just give you this kind of how we think algorithm of how to deal with these lesions. You would do your brain MRI and the spine MRI to be sure that you have no droplets and seedlings, and you do your tumor markers. And then either the markers are positive or they are negative. If they are positive, alpha-fetoprotein beta gonadotropins, this is most likely a germinoma. So tissue diagnosis is not required, then you go for radiation or chemotherapy. If they are negative, then you may want to be sure by taking biopsy or by doing surgery. So either stereotactic biopsy or open craniotomy. And once you do that, then you will come to the staging of the tumor, and you may add adjuvant treatment according to the pathology. So this is the algorithm of treatment of these tumors. Now, whether they have preoperative hydrocephalus, they would decide what to do, hydrocephalus or no hydrocephalus. If there is hydrocephalus, you have so many options. But the last one that one should think of is to put a shunt. There's no need for a shunt, because you can always save the patient's life by just putting external vein that it is a from an emergency. It is not an emergency and the hydrocephalus is not that bad, then you can operate and you can open the channels of CSF without the need of any kind of shunting. So, as I said, if you have the positive markers, you would diagnose germinoma, and then there is no need for surgery. And look at this, a huge germinoma, and this is after radiation, without surgery. So surgery with the radiation in the pineal parenchymal and in the pineoblastoma, they're bad prognosis. As I said, CSF, so many things that you can do before jumping on a shunt. To me, a good shunt is no shunt. Don't put a shunt. You would not like a shunt to be put in the head of your daughter or son or whatever. So don't put it to the others, and don't stop claiming that this was to save the patient's life. This is a big lie. You can save the patient's life by putting a drain. So people are still living in the third world countries, including Middle East and Arab countries, in the 60s, where the only treatment for these pineal tumors was to put a shunt and then send for the therapy. So this is a call for people to wake up. This is 2020, 60 years later. So don't stay in the past. I call it the Arab world and the third world countries disease. A shunt is a disease in the hands of young neurosurgeons and residents. This is the only surgery that they do time and time again without just stopping to think about it. So every pineal tumor is treated with a shunt. So different shunts. And the worst about it is the direction. Look at this. Even the direction of the shunt is wrong. They don't know where they are going. They just put it because they do it once and then they just are left alone to manage and kill patients and maim patients with a procedure that can be avoided. And the worst is, of course, to put bilateral shunts. I've seen this many times. Example of this case here. Shunt, 11-year-old patient. They put a shunt and they refer for radiotherapy. To me, this is a crime against humanity and it has to be stopped. I will not stop, I will not weaken making this point. A shunt not to be put in the heads of patients unless it is mandatory. A shunt is a good surgery, but just use it whenever it is really indicated, not because you cannot operate, not because you are mediocre surgeon. Again, these are patients referred to me after a shunt from somewhere else, from sent elsewhere. Here is a frontal shunt. So I'm just showing the cases that I received with the shunt being put in. And this is a shunt that has been put, and look at the complications here. Pneumocele, hygroma, subdural hematoma, you name it. So not only that it is not indicated, not only that they lied about it by just saying that we had to, I have no idea. All these shunts are to save patients' life. All these surgeries are done at 3 o'clock in the morning to save patients' life. As I say, that a shunt needs at least an hour in the competent hands. External drain needs about 3 minutes. So why don't you save the patient's life by putting external drain if you are really saving his life? Just showing you the cases that I had to deal with these shunts. Of course, this patient had hemiparesis. Just showing you the cases that I've dealt with who had shunts before coming into my service. So what are the approaches to operate on these pineal locus tumors? So many. The main thing is the tentorium, so you go infratentorial above the cerebellum or above the tentorium in medial or lateral direction. You can come through the corpus callosum, posterior intercallosal, or passing through the ventricle itself. So you have also to look at the straight sinus and see what is the tumor. If the most of the tumor is above the tent, you go for the supratentorial. It is most of the tumors infratentorial, you go infratentorial. So these are the general plans of these cases. Steps or the kinds of approaches, the infratentorial supracerebellar approach, like this, you will see these bridging veins. They could be in the midline, so vermin bridging veins, or they could be lateral hemisphere bridging veins. Try to avoid cutting these veins because you may cause major infarctions. Rotatorily, don't cut any draining veins unless you have to, unless you cannot really operate except by taking this vein out. If the veins are concentrated in the middle, then go laterally and find a window there. Some people even, they go and cut the tent and just depress the vein so that it is not under pressure when retracting the cerebellum. So this is the view that you would see in the infratentorial supracerebellar approach, these veins. So you may go trying to find a window here, or a window here, or even a window here. And remember the tentorial venous sinuses are very important. So once you are in, you deepen your approach, and you reach to the, as I said, the thickest arachnoid ever in your body, and it is very thick in the midline, and it is less thick laterally. So sometimes you start the dissection here and come in. You always find a midline vein, that is the precentral vein, and you'll find a certain branch, which is the pineal vein, superior pineal vein. So this is the precentral vein, and laterally is the vein of Rosenthal. So vein of Galen, vein of Rosenthal, and you will find your tumor there. So this is the supracerebellar infratentorial approach. The other approach that you need, and as I said, you need this if the most of the tumor is above the tent, is by going this way. Here you have less draining veins. You track the cerebellar lobe this way, and if this is the straight sinus, you take a safety margin of 2 centimeters, and you cut this tentorium, remembering the tentorial venous sinuses inside this way, and remembering that sometimes they are really very, very wide. So once you do the extraction, this is the midline, this is the straight sinus here. So you do your cut in this way. So here you open the tentorium, and then this is the lateral, the basal vein of Rosenthal, and this is the tumor of the pineal. If you want to extend the incision and do more retraction, you will come to the wide space there. Endoscopy, of course, has a place, and it's increasingly taking a very important role. Endoscopy is the future of neurosurgery. I have no doubt about that. And whether you are doing a rigid endoscope or flexible microscope with 30 degrees, 45 degrees, or straight, you can get to the pineal region by going through the foramen of Monro. These are some of the pictures taken by the endoscope. You can see the vein of Galen, you can see the tent, you can see the occipital lobe, you can see the basal vein of Rosenthal. This is a view through the endoscope into the third ventricle. This is the roof of the third ventricle. You can see both intercerebral veins, and this is the foramen. This is foramen of Monro. A beautiful view, and this is the interthalamic adhesion. Paper published about pure endoscopic resection of pineal region tumors, pure endoscopic removal of pineal tumors. and this paper about the prevalence of pineal cysts in children and young adults, which I alluded to. So it's been used in an increasing number of cases. And this is pre-endoscopy and this is post-endoscopy. Radiotherapy can be used and must be used in the majority of the patients of the pineal, especially when you do subtotal or near total resection. Gamma knife is useful, and just remind you that we had the first gamma knife in the Middle East back in '96. And that's, of course, me treating the very first case in 1996. Radiotherapy forms IMRT or conformal or proton beam. It can be used. Also chemotherapy, cisplatin based, especially for germ cell tumors. What about survival? Pure germinoma, they have a beautiful survival. 5 years, 95%, 10 years, 88. High-grade glioma is less. Malignant germinomas, of course, it's very poor. My series in the last 30 years, I had 92 patients of the pineal location tumors. I've lost a follow-up on 20. I have 72 to present to you. Male to female was 3:1. And this is some of the MRI pictures of these patients. I collected it for you to see the various sizes and pathology in that area. Still in the axial cuts and the sagittal cuts. CT would show you calcification, and you have to differentiate between a normal calcification of the pineal, which is well known, or the abnormal calcification. So normal pineal gland calcification is a well-known fact, but abnormal calcification can occur in tumors, whether there's hemorrhage and calcification inside the tumor, and you will see the relationship of the tumor or the lesion with the vessels. You can see the intercerebral vein going through the vein of Gallen here. So this is intercerebral vein on this side, seen, not seen on the other side. Same thing here. MRA, MRV are mandatory to me. They are part and parcel of the MRI. I cannot operate, I cannot diagnose without these three MRI, MRV, MRA. This is the normal pineal size, 10 to 14 millimeters. Pictures of general of the pineal germinoma, how they look in T1 and how they contrast enhanced. So diffusion is important here, especially if you are dealing with the pineal epidermoid. So MRI can give you a very good appearance in all the sequences of the MRI would help you in trying to reach to the diagnosis. That is also combined with the biomarkers. Again, certain features of the MRI appearance, germinoma, different from teratoma, pineoblastoma, each has own characteristic, how much hemorrhage, how much calcification, how much brain invasion. So if you study this with your radiologist, then you may reach to a diagnosis. Couple this with the biomarkers, with your experience, with the age of the patient, then you may reach to a diagnosis. If it is germinoma, then no need for biopsy or surgery, send for radiotherapy or chemotherapy. Always remember to do the spine MRI to make sure that you don't have droplet metastasis. In my series, the surgical approaches most used was the infratentorial supracerebellar. Of course, I use the other approaches according to the extension and the size of the tumor. I've achieved gross total resection in 42 patients, subtotal resection in 30. These are the 72 patients that have long follow-up. And look at this. 42 out of the 72 that I received had shunt, all before they were referred to me for surgery, and all were done at St. Elsewhere Hospital. Complications, I do this in the sitting position. I have complications like air embolism, 10 cases, but I've never lost a case for air embolism. We are experienced in the air embolism with our anesthesia team. We have hundreds of these cases. We've never lost a case for air embolism. And what we say, there is air embolism in every case you do in sitting position. Some of them are detected, some are not. If they are detected, there are ways of getting rid of it. I lost one patient in this group. This is the patient. Also, she had a shunt before. I went in, removed that, and on the night of surgery, she arrested. And I think it's because of some hypothalamic involvement. Some of the cases, this parenchymal tumor in this man from the Gulf area. This is before and this is after. This lady from Saudi Arabia with this parasitic astrocytoma. And this is the follow-up on her. This man from Kurdistan in Iraq with this huge tumor following surgery and radiation. Have lots of meningiomas in that area. And some of them are shown here. One case before surgery and after surgery. Epidermoids, examples. In this case, if you go posterior transcallosal, that would do, because most of the tumor is above the tent and it is within the ventricle. This is the follow-up of the patient. This is a true pineal locus epidermoid, being post-op. The beauty of the epidermoid of the pineal is that you see anatomy as you never see it anywhere else. You would see the two legs of the pineal gland. This is one of my cases, and I think you can see clearly the two legs, the upper leg or the upper arm, if you want, coming from the ependylar commissure, and the lower coming from the posterior commissure. Before and after. 27-year-old female patient from the Gulf. Before and after. This is the histology, the immunostaining. Lady from West Bank of Jordan, from Palestine Authority, with this arachnoid cyst before and after, and the follow-up. And the cases that we treated with the gamma knife, especially in the post-operative cases. This case of lipoma of the pineal locus and how it looks in the infratentorial supracerebellar. You can see the yellowish appearance of this tumor, and this is the trochlear nerve being dissected, both sides, and this is the patient post-operative. I use the sitting position or semi-sitting position. Again, depending on whether the tumor is above the tent or below the tent. This is the semi-sitting or sitting position using the navigation and the neuroobservation. This is the same case that we described, the lipoma. Now I'll just show you some of these videos and we'll be finished. We just changed the 3D. We always record in 3D, but we have the system to convert it to 2D. So this is the appearance. Here we're trying to find a window, where to go, so don't sacrifice in the vein unless you have to. Most of the time you'll see you come to this very thick arachnoid, and then this is the pineal tumor. Again, in the pineal tumor, You have to try to remove every ion of it. If you can, remove the thick arachnoid to prevent recurrence. It's not enough to just to suck this soft tissue tumors out. And you can see here how much they are stuck to the blood vessels and so on. So you have to be patient and try to really take it out completely, not just to decompress, as people would use this term, which I hate. We have done decompression. You have done nothing. It has to be almost complete excision, not on the expense of the patient, of course, but you have to go in with the mental state of that. I want to take every ion of this tumor, including the thick arachnoid. So you can see that it surrounds the blood vessels and get itself stuck everywhere. This is the best chance of the patient to get rid of this tumor. So don't stop saying here, oh, I have done decompressed the tumor. It's not enough. Now look here, you can see here the choroid plexus of the third ventricle beneath there. Again, being patient and knowing your anatomy well and removing this thickened arachnoid with the tumor. Every piece of thickened arachnoid that you can remove should be removed. So when you finish, you wash and wash to prevent the chemical meningitis. And look at the view you have here. The whole third ventricle in front of you. This is the interthalamic adhesions here. And you can see the vein of Galen, vein of Rosenthal, both sides. Here you can see the foramen of Monroe and the choroid plexus and the roof of the third ventricle. Okay. So another case, and I'll just go quickly through that. Again, trying to find a window, finding the window between the veins, and coming here to the thick arachnoid. Here, you have to make this courageous decision. This is the thick arachnoid, and there is a bluish color underneath. Are you dealing with the vein underneath or what? So you have to be really informed, very well informed about where are the veins and how to dissect these thick arachnoids. So laterally, it's easier. Medially, it's more difficult, but eventually you will find a window to take the tumor out. This is the tumor, and you start debulking it, dissecting it from the surroundings. I don't use the word decompress. I've never used it because I hate it, and I think it's used indiscriminately to describe the inefficacy of the surgeon and his lack of knowledge and experience. Decompression means nothing. So now we are in the cavity of the third ventricle, dissecting it from the walls of the thalamus and the big veins, as you can see. Here again, you can see the telechoroidea of the third ventricle. Both internal cerebral veins are there. Still some tumor to be removed. Here, still a tumor hidden by these vessels of the veins, I mean. So you dissect, get it out. So this is kind of radical resection that you should aim to, not on the expense of the patient. It is for the benefit of the patient, not at any cost, not to get just beautiful post-operative MRI. But the patient deserves this from you, deserve that you should be patient, spend your time trying to remove his tumor out. Again, the roof of the third ventricle, thylakoide, the vein of Galen, the vein of Rosenthal, the precentral cerebellar veins which are preserved. You can see vein of Galen there. You can see the cavity of the third ventricle. Another case, again, trying to find a good plane of cleavage. This is the lipoma which I told you about. Some people would say, why should you operate on lipoma? Because it was symptomatic. This patient came from Bahrain with the trochlear nerve paralysis or paresis, and with all the manifestations of hydrocephalus and increased intracranial pressure. So we did a very good job here by removing it, finding the trochlear nerve, as you can see, dissecting it. Here we're taking the tumor from the quadrigeminal plate. And this is the appearance that you get. This is the pineal. This is the normal pineal gland. Another tumor here. Again, finding the plane of cleavage. You can see that we're finding a good plane of cleavage from the quadrigeminal plate. You work right and left, right and left. This is on the right side. So debulk, dissect like everywhere. This is the thick arachnoid that I'm telling you about, to make sure that there's no venous structure underneath. And this is a piece of a tumor embedded in the pulvinar of the thalamus. Being patient, you aim for the best for the patient by taking his tumor out completely, even if you need to go radiotherapy. Radiotherapy with a small volume lesion will give you the best results. But radiotherapy with the main bulk of the tumor there will give you no result whatsoever. And this is attested by all the radiation oncologists. It is volume related. So stop talking about decompression and sending for radiotherapy. This is not the practice. This is your practice that you have invented. Again, here the cavity of the third ventricle. This is interthalamic adhesion, as you can see it here. I think we finished here, and I'll give the microphone to you.
Okay, Dr. Sabay, you want to go right into another presentation, or you want to take questions? What would you prefer to do?
I think we'll go for Professor Özdeman's presentation, and then we'll take the questions from to both sides.
Okay, very good.
Thank you, Professor Sabay. It is just such a pleasure to see your surgeries.
Thank you.
It takes mastery to make these surgeries look easy. These are like really difficult surgeries, but in your hands, they look just easy. Thank you for the words. Today, I would like to share our clinic's view on the pineal tumors. And let me share the screen with you.
Could you please introduce yourself, Doc?
Certainly. My name is Dr. Koray Özduman. I'm a neurosurgeon at Acıbadem University in Istanbul, Turkey. And I mostly do like neuro-oncology, and I'm also responsible for the gamma knife unit at our center, which Professor Sabay and Professor Pamir, from my chairman, have pioneered in the Middle East, Professor Svei's approach was the first, and he brought the first gamma knife to Jordan, which was the first gamma knife unit in the Middle East. Then came the second machine in Istanbul, Turkey, at Marmara University. And since 1997, 1 year after Professor Svei, we have been using this gadget at our. Today, I would like to talk to you about pineal region tumors. And these are a very heterogeneous group of tumors. And I'm not going to solely rely on our experience with gamma knife, because these are very heterogeneous group of tumors. Some of them are treated with gamma knife, some of them with surgery, some of them with combinations. And I would like to share with you our take on the pineal region tumors. First of all, we group these tumors into 4 categories. We divide these tumors into pineal gland tumors, then posterior third ventricular tumors, then brainstem tumors, and the ones that are located in the tentorium. So these 4 groups make up the real majority of these tumors, but there are some orphan tumors that I would like to talk to you about also. The pineal tumors are made from the germ cell tumors, and Professor Svei has shown excellent examples. And our take on these tumors, I will tell you again, germinomas, choriocarcinomas, yolk sac tumors, and embryonal carcinomas. These are mostly treated with chemotherapy first and then radiation, and we only use surgery in very resistant cases. Teratomas are basically treated with purely with surgery, and pineal parenchymal tumors are a different group of tumors. These are changing very significantly in their nomenclature in the last 5 years or so. Also in the World Health Organization 2016, the classification, the intermediate differentiated tumors group came into being. So pineal tumors are basically germinomas and the ones that are coming from the pineal gland parenchyma per se. Then we have a small group of posterior third ventricular tumors, which are really rare tumors like the chordoid glioma, diffuse leptomeningeal glionodular tumor, or like these are really very rare tumors, and these do not make up the majority of this region. Then we also deal with brainstem tumors, not necessarily only gliomas, but also lymphomas, metastases, hemangioblastomas that can be localized into the midbrain, to the mesencephalon. And the gliomas, the group of gliomas, are different in children and adults. And in children, you see the tactile plate gliomas, which are a benign garden variety of these tumors, which never, like almost never grow and never need any kind of surgical procedures except for cerebrospinal fluid diversion in the form of third ventriculostomy. And pilocytic astrocytomas, ranging to diffuse midline gliomas. These are ranging from very less aggressive to more aggressive in children gliomas. In adults, we again run into pilocytic astrocytomas, glioblastomas, but in the last few years we have switched to defining these tumors based on their genetic findings also, which complement the histopathology to give you a more precise grouping of these tumors. And last but not least, within this group, we also still have the diffuse midline gliomas, which are a very aggressive type of tumor, mostly localized to brainstem and the bilateral thalami in children and also adults. Tentorial tumors make up the minority in pediatric cases, but meningiomas turn to be more common tumors in the old and elderly population. Finally, we have some orphan tumors like the atypical teratoid rhabdoid tumors and other embryonal carcinomas, not embryonal carcinomas, embryonal tumors of the childhood, and their exact tissue of origin is less well defined. When you look to all these tumors, and from large catalogs, such as the United States Tumor Catalog, the CBTR-US, Central Brain Tumor Registry of the United States. In the latest version, it gives up the differentiation of central nervous system tumors in different age groups, that you see 15 to 19, 20 to 24, 25 to 29, like early adulthood and later adulthood. These are different age groups. And you're seeing that the pineal tumors make up to 3.4%, going down to around 1%, and not being not very much seen in the adult population per se, when you're looking for pineal tumors. So this tells us that pineal tumors are a disease of children and the young largely. But again, meningiomas increase in their incidence over every decade, and you start with it being a common tumor in in the third decade, with about 5 cases per 100,000, going up to 50 cases per 100,000 over in the 8th decade of life. So the meningioma incidence increases with age, so you see more and more meningiomas in the adult population. It's a very nice example for the tentorial type of tumors. And our university has a large, our department has a large experience on these. We have over 1,200 surgically treated meningiomas, and like over 2,600 gamma knife procedures for meningioma. So we have a large collection of them. And among these, the tumors that are located in the tentorial incisura behind the brainstem, and the ones that are called the falcotentorial meningiomas are the types that are located in the pineal region. These can be approached with many different surgical approaches, and just as Professor Subay elegantly expressed, the ones that are extending above the tentorium are usually approached from above, and the ones that are located below the tentorium are approached from below the tentorium. Our approach is slightly different from what Professor Subay is advocating, because we do not use the sitting position or the semi-sitting position at all at our department. It has been our departmental policies for the last 30 years or so, not to use the sitting position because of the air embolism problems and the medical legal problems that it can bring to us. Like I told you, like for meningiomas of the tentorial incisura extending infratentorially, we use the lateral suboccipital approach. We don't use the midline approach, but the lateral suboccipital approach, because the tentorium has a angular shape, which is more steep in the midline and less steep, more horizontal when you approach it from the lateral portion. But with this approach, a meningioma that you're seeing here, this is a type Yaşar-Gil type T3 and -2 because it's infratentorial, could be very elegantly excised, as you're seeing in the lower series. Again, in meningiomas, that's another T3 type 3 because it's both supra and infratentorial, but its majority is in the infratentorial space. It was approached from below the tentorium with a nice resection. The tumors that are extending both supra and infratentorial, we use a combination of the subtemporal approach combined with the same approach that I was telling you about now, the lateral suboccipital approach. This combined approach gives us, again, the possibility of getting nice resections in these, in the meningiomas of this region, even in larger ones like the one that you're seeing here. For tumors that are located mainly supratentorial, we use the occipital interhemispheric approach to approach these lesions. Including the falcotentorial meningiomas, this gives us a nice exposure of the tumor from above. So where's the role of gamma knife for these type of meningiomas? The results of gamma knife in this region are excellent when compared to other types of meningiomas, because we have spoken in the presentation about the parasagittal and falx meningiomas, that these type of meningiomas, parasagittal and falx meningiomas, are very complicated meningiomas because of the surgical problems they pose, because of the problems they pose to gamma knife surgery and also to radiation therapy, because they are aggressive by nature. But tentorial meningiomas are not of that variety. We have showed very clearly in a large collection of patients, all histopathologically and immunohistochemically, documented with immunohistochemistry, that the location is a very, very important, plays a very important role in the biology of these meningiomas. And in 89 tentorial meningiomas that were operated at our center, there were zero malignant cases, and only 6% were atypical meningiomas. So this gives us an idea that these meningiomas are mostly benign meningiomas. And that's therefore we tend to use gamma knife procedures in the falcotentorial meningiomas, and meningiomas of the tentorial incisura very commonly, very deliberately. Here you're seeing an example that was referred to our center after a failed attempt for surgical removal. The patient was operated via an interhemispheric approach with a gross total resection of the tumor. But 3 years after the initial operation, we saw a recurrence of this tumor at the tentorium, at the falx actually, and this was treated with gamma knife procedure. In the upper row, you're seeing the original size of the tumor, and lower below, you're seeing that the tumor is responding nicely to this gamma knife procedure 1 year, volumetrically 1 year after the gamma knife procedure. But we also use the gamma knife primarily also with small to medium-sized meningiomas. Here you're seeing an example which has stayed stable in size 40 months after the initial gamma knife procedures. Again, you're seeing a small meningioma that was treated at the falcotentorial region and stayed volumetrically the same 1 year after the gamma knife procedure. Again, here's a further example, again, a small meningioma that was treated primarily with gamma knife and has remained stable volumetrically. So we call this tumor growth control 12 months after the gamma knife procedure. So as you're seeing, the results of gamma knife are quite decent using the gamma knife in tentorial incisura meningiomas or the falcotentorial meningiomas. Looking to pineal tumors, again, like I expressed before, there are two types, the germ cell tumors and the pineal parenchymal tumors. Our institutional approach with those is in germinomas, choriocarcinomas, yolk sac tumors, and embryonal carcinomas. We try to look at cerebrospinal fluid and blood markers. And we also take a biopsy from these samples. And when a germ cell tumor is identified, then the patient is referred to chemotherapy and radiation therapy after a volume reduction. This is chosen because the volume reduction allows us to give us our radiation oncology colleagues to give lower doses to smaller volumes of tumor inside the brain. With teratomas, we try to be aggressive with the surgery. I will show you a few examples of these. With immature teratomas, these are supported with adjuvant treatments also. With pineal parenchymal tumors, it's different. Pineocytomas are WHO, World Health Organization grade 1 lesions, and they respond nicely to gamma knife radiation because they are circumscribed, localized lesions. But the pathology needs to be well identified because pineal parenchymal tumors of intermediate differentiation, pineal papillary tumors, or pineoblastomas are aggressive tumors, and these need to be treated more aggressively with fractionated radiation treatment rather than radiosurgery, stereotactic radiosurgery using gamma knife. Our clinic has published our algorithm for the treatment of pineal tumors just last year. Again, like I told you, with teratomas of the pineal region, like the example that you're seeing here, we try to do as an aggressive surgery as possible. As you're seeing here on the second example also. For these, we mostly use the occipital transtentorial approach, which gives us a very nice view of the pineal region with the tumor being exposed here. With the head in the dependent position, as you're seeing here. With the pinealocytomas, they respond favorably to gamma knife treatment, but like I told you before, but it's almost mandatory for us to give a pathological diagnosis. And today, this is mostly done through an endoscopic approach. With the endoscopy, we can perform a third ventriculostomy, and third ventriculostomy gets rid of the hydrocephalus problem that's common in these cases. And by changing the direction of the endoscope, it's possible to get a biopsy from the pineal region posterior third ventricular approach. And this gives us an assurance about the pathology. And if it's a pinealocytoma, then we treat these patients with a gamma knife procedure. Here you're seeing how such a procedure looks. Tumor is located at the posterior part of the third ventricle, similar to the cases that Professor Sbey has shown previously. Again, here you're seeing a smaller example, a pinealocytoma, like 30 months after the initial procedure, the tumors remain stable. And 46 months after the initial procedure, again, this tumor has remained stable after an initial biopsy and a third ventriculostomy in the beginning. So gamma knife has a role in pinealocytomas only among the pineal region tumors. When we switch to the third group, the brainstem tumors, again, them all being gliomas, they are very diverse in their behavior and the treatment strategy that we have to take for those tumors. Pilocytic astrocytomas are one of the least aggressive, the slowest growing type of tumors. And we very seldomly operate on these cases, except for they present with progressive symptomatology or progressive change in radiological outcome. Here you're seeing a 33-year-old female who presented to us with chronic headaches. She was diagnosed with a tumor that was protruding away from the tectal plate unilaterally, with some contrast enhancing inside. MR spectroscopy showed basically a grade 1 to 2 lesion with no hyperperfusion on the perfusion weighted imaging. We planned the endoscopic third ventriculostomy and the tumor biopsy in this patient using two trajectories here you're seeing. In the same procedure, the patient underwent both a biopsy and the third ventriculostomy. After the third ventriculostomy, the ventricular size went down and the patient's headaches resolved. And the pathology was reported as a pilocytic astrocytoma, which we also backed up with molecular genetic analysis. And this molecular genetic analysis showed a translocation, which is prototypic for a pilocytic astrocytoma, the BRAF KII 1549 fusion. And therefore we administrated gamma knife procedure to this young lady who did very well after this course of treatment. My second case is a pediatric low-grade glioma. It's a 14-year-old male who was diagnosed in 2017, 3 years after our approaches, with a tectal plate lesion, again, slightly contrast enhancing. But after a watchful waiting period of 3 years with MRIs every 6 months, the patient presented before his next follow-up with a new onset of double vision. And on MRI images, like increased volume and increased contrast enhancement, change in the contrast enhancement pattern of the lesion was noted. So therefore, we went in with again, occipital transtentorial approach and resected the contrast enhancing portion of the tumor, both to get a biopsy and also to get this, the aggressive part of the lesion out. The pathology was reported as a pediatric low-grade glioma. This is somehow an arbitrary definition, but these tumors, some of these tumors in the pediatric population, not in the adult population, present both with features of a pilocytic astrocytoma and also a diffuse astrocytoma within the same tumor. And the literature indicates that these tumors behave benign, and therefore we again decided to administer gamma knife radiosurgery to the rest of the tumor, of the non-contrast enhancing portion of the tumor after the first surgical resection of the lateral portion, the contrast enhancing portion of the tumor. And already 1 year after this gamma knife procedure, we saw a decrease in the volume of the T2 hyperintense portion of the tumor, and the boy is doing quite well with no neurological deficits currently. The first type is very, very much different from the two glioma examples that I've given you before. This is a 75-year-old male who presented to us with an unsteady gait. You're seeing that the tumor is located actually basically inside pulvinar thalami, but extending into the midbrain, into the mesencephalon. So we did a stereotactic biopsy from this patient, and the pathology came out as a glioblastoma, but we again confirmed this diagnosis with molecular features. But because tumors with different molecular features behave very much differently in this, even in the elderly population. The tumor came out to be a molecularly defined glioblastoma. As you know, there are 3 molecular definitions of a glioblastoma these days: the telomerase mutation, third mutation, the chromosome 7 amplification, chromosome 10 loss pattern, which is called the 710 pattern, and the epithelial growth factor receptor amplification. These are the hallmarks of a molecularly defined glioblastoma these days. And luckily, the patient's tumor was MGMT methylated, which gave us the possibility to treat the patient both with radiotherapy and temozolomide, oral temozolomide. This is an early operation. It's only 2 months after the operation now, but early 1 month after the radiation therapy, the patient's tumor regressed slightly in size, and this gave us hope of keeping the tumor under control at least for some time. The fourth example that I'm going to give you is the worst of all these types. These tumors are called the diffuse midline gliomas, H3K27M mutant. This is a specific genetic mutation in the histone gene. And these histone genes are the hallmark of the diffuse midline glioma variety that's being called now. This tumor type was first shown in diffuse intrinsic pontine gliomas. And these are very, very, very aggressive tumors. In our series, in the adult population, there are only few examples to those. And only one of those located in the pontine region has survived beyond 1 year. All the other cases, all every single one of them has deceased before 1 year before the first year of starting the treatment. And basically the treatment, the surgery is excluded because there's nothing that we can offer these patients with this very aggressive type of tumor. Here you're seeing a 39-year-old female who presented to us with left-sided facial hypoesthesia. You're seeing a tumor. The tumor is located in the pulvinar thalami again, with faint contrast enhancement. The MRI features were, we also done MR spectroscopy and perfusion weighted imaging, which show the diffusely highly perfusing lesion with the MR spectroscopy findings of intermediate grade, like grade 3 lesion. But this is common for these type of tumors. Therefore, we decided to do a stereotactic biopsy, and the stereotactic biopsy came out as diffuse midline glioma, H3K27 mutant. So this is an unfortunate diagnosis, but in the last few years, some new centers from Europe and the US have reported in using some new experimental drugs, funnily some dopamine antagonists for the treatment of this type of tumor, which we also have tried in this young lady who's suffering from this disease. But why do we always do biopsy in these lesions? Do we always need the pathology? We have seen that we always need the pathology for a pineal parenchymal tumor, and also we need it for the gliomas, at least to know how the tumor is going to behave, and also to exclude some differential diagnostic dilemmas. Here you're seeing a similar case located in pulvinar thalami and extending into the mesencephalon, contrast enhancing with central hypointensity. Patient presents with hemihypoesthesia, 27-year-old female. Again, we do a stereotactic biopsy, and the result comes at lymphocytic vasculitis. So we definitely do need a tissue diagnosis in these cases, which I would like to underline in my presentation. So coming to the conclusions, pineal tumor regions are a very heterogeneous group of tumors. And the treatment depends on the underlying pathology. Whatever the tumor requires, we need to administer. So therefore, a pathological diagnosis is a must for these cases. The only exclusion to these is when we are 100% confident that this is a meningioma from very nicely done MRI images. We sometimes do direct the primary gamma knife treatment for meningiomas only, except for meningiomas. Other than meningiomas, we never do primary gamma knife treatment in any of these pathologies. So thank you for your interest, and thank you for your time listening to this talk. And finally, I wish to give the word to the master surgeon, Professor Sbey, once again. Thank you very much.
Thank you.
Okay, Dr. Sabea, whatever you want to do, you want to have questions or?
Yeah, we're happy to take questions and comments from anybody who's there.
Takes a while for people to get going.
So many questions that can be asked.
That's all right. I bet you Radab has a question. Can you unmute, Radab?
Good evening, doctors. Thank you, Professor Spey and Dr. Gray for the great presentations. Well, it's the only and the regular question that what is the role of biopsy in such a various kind of tumor that we can have in such sensitive and precious locations? Like if we had a suspicion for germ cell tumor where the radiotherapy would be the first line of treatment, and there was no response for the radiotherapy. So, Professor Spey, does that strong indications to go to intervene and get a biopsy?
Sure. So the question is related to biopsy of the pineal location tumors. I think the final slide from Professor Osman presentation that a tissue diagnosis is a must if you are in doubt. So the only case where you are not in doubt is when you have typical features radiologically of a germinoma, a true germinoma, and the positive tumor markers. Then you can go for radiation and for chemotherapy. Other than that, you need to have either stereotactic biopsy or you go for open excision and send it for pathology. So tissue diagnosis is essential. And the last case also presented by Professor Osman is this case of lymphocytic vasculitis in the pulvinar of the thymus. So this is kind of variations that people don't think about. You see, if you don't think of pathology, certain pathology, it will disappear from your mind. People think of a supracellular lesion like pituitary and craniopharyngioma. There are something like 80 pathologies there. And you have to think of each and every one of them whenever you see a supracellular lesion. So many cases of pineal location tumors, various pathologies. So don't be a prisoner of one or two diagnoses. Don't be a prisoner of one or two approaches. Tissue diagnosis is a must.
Thank you, Prof. And if you would allow to ask a second question.
Sure.
Of course.
Thank you. For that case of the lymphoma, which you present as a case report, did you treat it with steroids or you intervene directly?
Actually, that patient was referred to me from Iraq. And because it's coming from Iraq, you have so very much wide pathologies there, especially after the wars there and the use of chemical weapons and other weapons. So we are seeing lots and lots of abnormal pathology, not in neurosurgery only, but in the general surgery, in the gynecology department. We are seeing many, many pathologies, lots and lots of tumors coming from Iraq. So we did, you see, either this is a secondary lymphoma or a primary lymphoma. But lymphoma is on the list, and lymphoma should be on the list of differential diagnosis of any lesion in the brain. We forget about that. So we did all the investigation to see whether we have any primary lymphoma, bone marrow, etc., nothing. So we had to go for a biopsy. So we went for a biopsy of an accessible lesion, which was in the fourth ventricle. It was accessible, and it was a lymphoma. And if it is lymphoma, you just go for chemotherapy, nothing further.
Right. Thank you, doctor. Thank you, Prof.
Okay, this is a question for Dr. Correa. As the TM are mostly benign, which are its characteristics that become them to have an excellent response to gamma knife? Does that question make sense? I don't know. Does that make sense?
As I have I think I have, at least I have tried to underline in my presentation that gamma knife has very strict use in very few pathologies of this region. Pineal parenchymal tumors, except for pineocytomas, there's no role for gamma knife. Again, brainstem gliomas, hardly for any of them we use the gamma knife procedure. The tectal gliomas are watched and not treated. Pilocytic astrocytomas are mostly watched and managed with watchful waiting. So there are only few entities where we use the gamma knife procedure for these. The only exception is the first example that I gave you, like meningiomas of this region respond very, very nicely to gamma knife. And this is the one that we use most commonly. If I may, I have one single addition to Professor Sbey's comments. Recently, I came across a study that was on the germinomas of the pineal region. As you know, like when a germinoma, like a lesion, the diffuse infiltrating lesion of the pineal gland coexists with another lesion in the pituitary infundibulum, pituitary stalk, and the patient has diabetes insipidus. This triad gives us a very strong indication that this is a germinoma.
Sure.
A group of authors have collected all the cases from their center and from the literature. And they've concluded that even with the full presence of all three features, it was not 100% germinoma. Germinomas were somehow something like 95%, but the 5% granulomatous inflammations also came into the differential diagnosis and could mimic germinomas. And treating granuloma using chemotherapy plus radiation therapy will be a very, very poor treatment strategy. So therefore, whenever we try to get biopsies from these lesions. And the second issue is in the 1990s up to 2000s or so, we used commonly the stereotactic biopsy is for pineal lesions. But the risk of hemorrhage in pineal regions in stereotactic biopsy is quite high. It's uncomparable to the one that we are facing using the endoscopic approach and endoscopic biopsy from the posterior third ventricle. So that's why we push towards getting the biopsies from the third ventricular approach rather than the stereotactic approach in the last 10 years or so.
Okay, I'm not sure what Dr. Bocali means, but he says, please, the question is for meningiomas. Does that make sense? Am I missing something here? Okay, we'll just forget about that. Okay. Okay, more comments or questions from the panelists? This is your opportunity. I always say this. I think people are a little shy with this platform a little bit at first. I think with time, they'll become more comfortable. Okay. Go ahead.
Again, I'm going to use this possibility to ask a question to Professor Sibey.
Sure.
When you approach a pineal region lesion, what is the first thing that you do in these cases? Like, do you go to identify the veins of the region first of all when you're dealing with a large tumor? Because what I'm seeing from your presentations, you don't operate on tumors of garden variety. Your tumors are always very large, very difficult, very complicated cases, and cases that have been not diagnosed over extended periods of time. So these are very, very exceptionally difficult cases. So what is your approach in such a case? How do you start for a pineal lesion?
By studying the case very carefully. I sit for hours on end looking at the MRI, MRV, CT angio, CTA, CTV, conventional angiogram if need be. This is the most important part. And then I would decide what to do and how to tackle this. The variations of the venous anatomy there is variable and so great. And you have to know exactly where you stand and which way to go. So study of the radiology, even if I need to, money has no consequence to me. So I go for all the investigations I need. I would do CTA, I would do CTV, I would do conventional angiogram. I need every single information that makes the surgery easier for the patient. Once I'm satisfied, then I just proceed. And once I proceed, I have one goal and one goal only. That is to kill the tumor and take it completely out. People think of epidermoid as simple tumors. I think of them as monsters. They twist and go around structures and push the structures, and you have to take them out. Some people just put a sucker and take the contents out, and that's it. This is not enough. It will come back. And if epidermoid come back, there is no treatment. It is not radiosensitive, it is not chemotherapy sensitive, so you make the patient's life miserable. His only chance is that if you go and remove every piece of the tumor out of the pineal of the these lesions are really tumors. They are not cysts. So epidermoids are not cysts. There is no fluid in them. There is no cyst. Actually, they are made of solid toothpaste-like structures. And the first one to describe them as tumors, nobody else but Professor Yazerjil in his famous paper about 133 epidermoids there. He called them tumors because they are tumors and they can turn malignant and they can stick to structures. So once you go in, after all the knowledge of the anatomy, your aim is to remove every piece of the epidermoid tumor, including the thick arachnoid, because some of the cells are stuck there. Would I stop at a certain level? Yes. I'm happy to stop if I found that it is encircling basilar or encircling carotid or stuck to the sixth nerve and so on and so forth. But my aim is to take it out completely. I would not stop at early obstacle I face. I would go on, I will persevere unless I'm sure that I really gave the patient his best chance, his best shot. And then I stop. I raise the flag if I cannot proceed further, but not from the first obstacle. So this is my philosophy about these things.
Okay, very good. Any closing comments, questions from the panelists? Okay, if not, Dr. Sabea, Corey says he's indisposed the next couple of weeks. Are you going to be presenting next week, next Wednesday?
Yes, next Wednesday, I was thinking, Corey, can you unmute yourself, Corey?
Yes, certainly. Next week, our medical students are starting their rotations in the clinic. So I need to spare some time for them to really spend time for their treat, like for them actually.
Right. So for the next
if I may be excused.
Sure, of course, we'll excuse you for the next week, and I'll present my personal experience of primary CNS lymphomas, primary brain lymphomas. I have a good collection of cases, and it's a very interesting topic, and we have just met some of the cases tonight, but next week I'm going to present the primary CNS lymphomas.
Very good. We look forward to that. And let me just quickly show you, Dr. Sabea, what's going on with Neurosurgical TV for the next couple of days. There's a webcast. Can you see this okay?
Yeah.
Yeah, okay. We have management from Bangladesh tomorrow. A management strategy on endovascular management of AVMs with a Kazakhstan neurointerventionist.
Yeah.
And Friday we have one with the Surgery Club of Congo. It's in French. So you're welcome to that. Okay, Dr. Sabea, thanks for the time, and thank you very much, Corey. And thanks for all the panelists for coming. So we'll close this now. See you next week.
Thank you.
Good night.
Bye-bye.